Hi everyone, this presentation is going to be focused on malnutrition and obesity. Your presenters are Kelly, Molly, and Angela, and the content has been reviewed by Dr. Jillian Wennick. So going into the presentation itself, we will be starting off with introductions and definitions by myself, Angela. The second portion will be on malnutrition and obesity by Molly, and then the third portion will be on treatment and therapy presented by Kelly. So what is malnutrition? Malnutrition can be defined as an acute, subacute, or chronic state of nutrition in which a combination of varying degrees of overnutrition or undernutrition, with or without inflammatory activity, have led to a change in body composition and diminished function. So this definition is from the American Society of Parenteral and Enteral Nutrition, also known as ASPEN. Note that the definition of malnutrition in general isn't actually well defined or necessarily consistent among the nutrition community as a whole, but we will be going by this definition for our presentation since it is from a reliable and relevant source. There is more research needed into malnutrition, how it coexists with obesity, which we will be covering later in this presentation. Some specific points about the definition here is that both over and undernutrition can lead to similar health outcomes, and there doesn't necessarily need to be that inflammatory activity present. Basically, the eventual outcome is that change in body composition and diminished function for the patient. And in addition, there are different, this can change during different disease states, which could lead to possible gaps in treatment. And then an additional factor that isn't included in here, but mental health is a factor just to keep in mind when it comes to malnutrition. Malnutrition diagnosis and practice settings can be broken down into three categories. There is starvation-based, which is starvation without inflammation. There's chronic disease-based, which is chronic mild to moderate inflammation, and then acute disease or injury-related, which has acute severe inflammation. So the starvation-based, an example could be anorexia nervosa. For chronic disease-based, examples are cardiovascular disease, type 2 diabetes, and for acute, it could be a major infection, burns, trauma, closed head injury. And just to note, the inflammatory response can often come from an infection in this case, but it doesn't necessarily have to. So although the definition of malnutrition itself isn't super well defined in the nutrition community, the practice settings usually use these three criteria. As our presentation is focused on obesity, we will be honing in on that chronic disease-based diagnosis, as you see in the middle. And just to note also for obesity, this diagnosis does come with that chronic mild to moderate inflammation. On this slide, we have criteria for who's considered at risk for malnutrition. On the left side, we have adults, and on the right side, we have children. So for both adults and children, meeting any one of the criteria underneath does put that patient in the at-risk category. Something to note here is that for both adults and children, it can be weight loss or weight gain, as well as that change in BMI at either end of the spectrum that can put the patient at risk. So how do clinicians assess for malnutrition? So the preferred screening tool is the Malnutrition Screening Tool, or MST, which has been recommended by the Academy since 2019. There are other screening tools such as the Malnutrition Universal Screening Tool, MUST, Mini Nutritional Assessment, MNA, Nutritional Risk Screening, NRS, among many others. As you can see here on the right, we do have the preferred screening tool, the MST. On the left here, we have a flowchart algorithm for diagnosing malnutrition, and this is recommended by the Academy of Nutrition and Dietetics as well as ASPEN. So here, the diagnosis is either a mild to moderate or severe malnourishment, and at the red arrow, you can see that need 2 of the criteria to be present for that malnutrition diagnosis. So here, the criteria are reduced energy intake, weight loss, muscle mass loss, body fat loss, fluid accumulation, and decreased hand grip strength. In addition, edema is often used supportively, so some sites use the presence of edema plus the 2 criteria for a diagnosis. Now switching gears over to obesity. Obesity is defined as a body mass index or BMI of greater than 30 kilograms per meter squared. We will be going more into BMI on the next slide. As for predisposition factors, these include sedentary habits and a high calorie diet intake, which leads to a positive energy balance, and the body then takes that energy and stores it as fat. In addition, genetics can favor energy intake and fat accumulation, which leads to natural differences in weight and weight gain or loss in individuals. As for prevalence and epidemiology, between those who are considered overweight and obese, they can make up the majority of the population in some parts of the world. For example, according to data from the National Health and Nutrition Examination Survey, about 36.5% of the US adult population is considered obese. Moreover, there is a higher percentage of women, middle-aged individuals, and non-Hispanic Black adults who are more likely to be obese. There are a few tools to determine and quantify obesity, as shown here. The body mass index, or BMI, is the most common and the one you're probably already familiar with. It is found by dividing the patient's weight in kilograms by their height in meters squared. Waist circumference is a measure of one's waist, and the waist-to-hip ratio is the waist circumference divided by the hip circumference. So there are some drawbacks for these methods. For example, the BMI is not as informative or indicative of health risks in certain populations. So examples are the very tall or very short, athletes who are very muscular. And also the waist circumference is not as informational once the patient is already in the obese category. In addition, Aspen definitions do divide obesity further. So there's obesity class 1, 2, and 3, and class 3 is defined as a BMI of greater than 40. And to wrap up this section, some factors that impact obesity are environmental. This can refer to locations, such as if someone is in a food desert, large portion sizes, a sedentary lifestyle. There are also psychosocial factors. So these are like cultural determinants, lack of access or means to afford healthy foods, food insecurity, even social acceptance of different body sizes. For genetics, we had talked about how obesity tends to run in the family, but these can also link with psychosocial factors. Certain medical conditions like hypothyroidism, depression, smoking cessation are factors. There are also metabolic changes, such as hormones, and these are also going back to genetics, so it's all pretty interconnected. But mainly here we're talking about hormones that can change and contribute to weight loss. And there's also medication side effects. So this could include classes like anticonvulsants, antidepressants, steroids, and anti-diabetic agents.
Hello, this is Molly, and we are now going to talk about how malnutrition and obesity intersect. So first of all, let's talk about obesity's impact on the body. Obesity is a strong risk factor for everything on this slide. We have our metabolic diseases, including metabolic syndrome, type 2 diabetes, atherosclerosis, or cardiovascular events, chronic diseases such as coronary heart failure, chronic kidney disease, chronic obstructive pulmonary disease, all of which could end up being end-stage organ failure, cancer and infections, pretty self-explanatory, acute complications, which could be due to insulin resistance or metabolic syndrome, hospitalizations due to the link with chronic disease, with cancer and infections, with metabolic diseases. It all links together. And when obese patients end up in the hospital, they do tend to end up in the critical care unit, of which 1 in 3 intensive care unit or critical care unit patients are obese. On this slide, we have a couple examples of how the inner workings of the body get changed due to obesity. We have a bunch of energy metabolism changes that occur, including metabolic abnormalities, including things like gut nutrient sensing, hormonal systems that tend to change, or CNS sensors that, upregulate or downregulate things like appetite, as well as hormonal changes that occur. Insulin resistance, this is correlated with fat accumulation in the abdominal visceral compartment, so the trunk of your body. We also see ectopic muscle fat accumulation. This tends to occur with impaired adipose tissue, fat tissue expansion, and this is also associated with tissue and systemic insulin resistance, which we mentioned above. Mitochondrial dysfunction occurs. This is mainly due to excess reactive oxygen species production. This occurs inside your cells, and it ends up leading to oxidative stress inside your cells. This could eventually lead to things like apoptosis or cell death, which we definitely don't want happening in our body. And our last change is stem cell dysfunction. So this could end up limiting skeletal muscle mass maintenance in your body. All right, now as far as obesity with malnutrition, obesity comes with all of the risk factors that we just talked about. So if you add on malnutrition, you end up with a double burden of disease. The nutrition community is starting to refer to this as sarcopenic obesity. Our definition here is the reduction of skeletal muscle mass and function, which may be associated with excess body fat in persons with obesity. So basically, this leads to impaired micronutrient levels, which greatly affects your skeletal muscle mass. And both of those things combined can lead to worse outcomes for patients, such as increased length of stay when in the hospital, impaired wound healing, higher rates of infection, and higher rates of complications, as well as increased admission and readmission rates to the hospital. In some definitions, it is combined with age and the age-related decline in physical activity. However, more research is needed because sarcopenic obesity is not well defined by the nutrition community. So more clarity on this topic would be, greatly appreciated. Remember this list of criteria from a previous slide in our lecture. These are our characteristics on how to diagnose malnutrition. And if you add in obesity to trying to diagnose someone with malnutrition, it can add an extra layer of complexity to this diagnosis, mainly because it can be very hard to determine what is body fat loss versus muscle mass wasting versus fluid accumulation. However, I would like to note that some hospitals are using ultrasound to help better determine the fat muscle components, but at this point, ultrasound is not listed in the criteria to diagnose malnutrition, but we are moving towards that in practice. And here we have a case example of what happens when you have an intersection with a patient that is obese and they are, either at risk of malnutrition or are already nutritionally impaired. When they end up in the hospital, we have all of these other extra criteria that we do have to think about when treating this patient. So things like glycemic control, control of blood sugar, can be further exacerbated by any medication management that needs to go on in a critically ill patient that ends up in the intensive care unit. We have to think about things like hypertriglyceridemia and altered lipid metabolism because the malnutrition obese patient could have potentially impaired lipolysis as well as fat oxidation. They could also be at risk for non-alcoholic fatty liver disease which, if left untreated or unrecognized, could ultimately progress to end-stage liver disease. If this patient is in the intensive care unit and is on a ventilator, we have to think about weaning from the ventilator, things like increased CO2 production, which could lead to hypercapnia, which is excessive CO2 in the bloodstream. We also have to consider ventricular hypertrophy and fluid overload. So basically, increased blood volume is needed to maintain this, increased mass of an obese patient, which can lead to the depletion of minerals inside the cell and could then therefore lead to less effective myocardial contractility, so a less effective heart. So basically, all of these issues are things that add just an extra level of complication to a patient that has all of these, obesity and malnutrition issues going on. Individuals with obesity may present with true malnutrition due to inability to preserve body composition and performance, with loss of skeletal muscle and function that exert major negative influences on morbidity and survival.
Hi everyone, my name is Kelly. I'm going to be talking in part 3 about therapies and treatment goals. In relation to goals, we want to make sure we're obtaining a SMART goal. That means it is specific, measurable, attainable, relevant, and time-based. We want to make sure we're preventing further weight gain, and that could include reducing the current body weight with some kind of behavioral therapy modifications, weight loss medications, or just a change in overall exercise. A loss in 5 to 7% of body weight is considered appropriate for cardiovascular disease. To prevent or reduce the development of comorbidities, again, we want to make sure we're minimizing polypharmacy and preventing adverse reactions from treatment. We're trying to minimize those side effects such as hypertension, hypotension, high blood pressure, and hypothyroidism. We're trying to also improve the quality of life of our patients. In relation to treating comorbidities with mental health, this quote at the top is something that stuck out to our group as we were doing some research. In every group, women with depression were more likely to be obese than women without depression. I think this is important as we go about our pharmaceutical careers, and it was important to bring up in this presentation due to the link with obesity and depression according to the National Center for Health Statistics. With that being said, we need to make sure we're screening women and men at every age group to ensure their quality of life and their path to better health is further succeeded. It is also important to treat all comorbidities, but extremely important to factor in the impact that mental health has on the quality of life. When our patients see primary care physicians, a psychologist, even a dermatologist, it's really important to make sure that we screen them at every visit. Another statistic that was super important to our group was that 43%, that is 43% of adults with depression were obese, and adults with depression were more likely to be obese than adults without depression. So that's similar to what was on the last slide with women, but this is just a more generalized overview scope of the statistics. All right, we're going to move on to some non-pharmacologic therapies. The 3 major points I'd like to talk about on this slide are nutrition, exercise, and some surgical operations that can be done. First, starting off with nutrition, our research led us down many different avenues in regard to different diets, one being the low carbohydrate diet, a Mediterranean diet incorporating higher levels of omega-3s and vitamins such as calcium and vitamin D. There was a higher fat soluble diet, which kickstarts the breakdown of stored fats and lipids. There was a moderate level of evidence on vegan eating and intermittent fasting. But again, these are something that shouldn't be taken on by the patient without seeing a nutritionist. Caloric restriction needs to be discussed further with the patient and create smart, realistic goals that are obtainable. In relation to exercise, Weight reduction exercise such as walking or cardio that increases the heart rate above normal resting is proved beneficial with strong level of evidence. Swimming, cycling, using the elliptical, things that are less impact on the joints and bones also have a moderate level of evidence in our studies as well. The last option for patients is a surgery that will remove some of the lipids and stored fat. Again, this is a last resort option as many nutritionists and MDs are not going to choose this as a first line treatment. Going a little bit farther into the diets, again, the low-calorie diet would be the quickest way of losing weight. However, it's very difficult for patients to maintain that weight loss, and normally in 6 to 12 months following that diet, they regain that weight. A GI diet, which is something that I found very interesting, was not superior to any other diet, but again, it worked significantly for patients with type 2 diabetes as a comorbidity. And again, what this would do was target with trial and error which foods made the patients more congested, more bloated, and then worked out how to modify and tweak that diet. A high protein diet is something that is particularly effective for a lot of athletes, but again, in relation to our targeted group, it would reduce the fat muscle in our patients, and specifically the TAG, which is high in individuals with diabetes and have a comorbidity risk of obesity. Moving on to pharmacologic treatments, we want to make sure that we're minimizing adverse effects, improving the quality of life, eliminating polypharmacy, ensuring patients are receiving adequate care. And just a note, we want to make sure that the pharmacological therapy is only considered as an adjunct to all the behavioral modifications and exercise that we've already mentioned here. So this is just 2 therapies that I decided to highlight. There are many more coming to market daily. Ali or Orlistat is a specific medication that can be found over the counter at your local drugstore. Its method of action is a selective inhibitor, and essentially what this will do is target those gastric and pancreatic enzymes and bind so that the fat cannot be stored. The dose is 60 milligrams 3 times a day, and please note the side effects. Phentermine is a prescription prescribed over behind the pharmacy. Its method of action is appetite suppression, and essentially it increases the resting energy. The adverse effects of phentermine, since it is a controlled substance, are hypertension, dizziness, tremor, and a little bit of psychosis in less than 2% of patients. Again, at the end of this presentation, please note we do not know the specifics of your medical history, so this presentation is not a suitable substitute for personalized professional and medical advice. We ask that you consult all of your prescribers and your physicians properly, and this is a shared decision process. We thank you very much for your time today. We hope that you have enjoyed your Malnutrition Awareness Week. Again, if you have any questions, our names, pictures, and emails are on this slide. We hope you have a great rest of your week. Thank you.